Today, I have a very esteemed guest by the name of Dr. Robin Williams. I'm super excited about this because I have so much to ask, and you're such a smart person. So, I want to start off at the very beginning. You're an assistant professor. So, from what I gather, not only are you on the research side of things, but now you're on the teaching side of things. So, tell me a bit about the teaching side, meaning you as a professor, what your duties are at this point, and how long have you been doing it?
Yeah, and so that's something that's a little confusing to a lot of folks. And so actually, I don't really formally teach. So
Oh,
so my appointment, so I know assistant professors, most of the time we think about professors as being the ones who teach the next generation of
yeah.
learners. And actually, my appointment is both clinical and research. So I see patients because my MD allows me to do that, and I'm board certified in pediatric hematology and oncology. And then the other part of my job is I do research, hoping to come up with the next, some new therapies for patients with leukemia and lymphoma.
Yes, that's what I thought. And honestly, I'll ask you this question. I was at my own doctor's office the other day, and here's my question to you. When you're talking to lay people, I don't know if you guys know this, but you list off all these things, and I'm like, what? Huh? So if I were to ask you to dummy it down quite a bit and say to folks, okay, this is exactly what Robin does, what would you say?
Okay. So my job, like I said, is twofold. I would tell people that I am a doctor and I
Right.
do all the doctoring things to help pediatric patients, typically those with leukemia and lymphoma. And then the other side of what I do, like I said, the research, the most basic way to explain it is that I have technicians that work for me and we come up with ideas to find ways to make patients' own cells, their own fighter cells, fight cancer.
Got it. Okay, thank you so much for that. So
Yeah.
this way everybody gets a broader idea of that. Now I'm going to break down each one of your job functions. First off, I know in 2020 you were the co-founder of a clinic for SOT patients. So tell me a bit about the expansion that's gone on from 2020 to this present point in time as far as the clinical side.
Yeah, so this was important for me because, again, being an oncologist and someone who deals with cancer, a lot of people don't realize that having received a solid organ transplant actually puts you at risk for a lymphoma-like condition called post-transplant lymphoproliferative disease. And what uh, almost always drives it, but not always, is this virus that most people only know of because it causes mono. So if I tell you that the virus that's a problem here is the monovirus, most people are like, oh, I know that. When we talk about it, we talk about it as Epstein-Barr virus or
Yeah.
EBV. And within the medical community, that makes a lot of sense. But I'll be honest with you, by and large, if I just use those letters to patients or even the full name to patients, most people have never heard of it. And then when you say mono, they sort of do, and it sort of clicks. And so what happens is that by time you're 18, 90% of the population has been exposed to EBV. Only a small percentage get mono, but everyone's heard of mono because someone was out of school for 3 or 4 weeks when we were kids. And so you're like, they had mono, and you might think to yourself, well, I must have never had that because I never had mono. Most of us get EBV, that virus, and then have a cold, and then we move on. We don't have a lot of symptoms from it. So it's still only a small population that even gets mono per se. But by the time we're 18, 90% of us have EBV. Most of the kids getting solid organ transplant, very young, have never been exposed. So the first time that they encounter that virus is when this organ that has the virus is going into their body.
Yeah.
And coupled with that is that we are giving them a lot of immunosuppression to make sure their body doesn't reject that new organ. And that immunosuppression makes it very hard for that child's body to fight that infection that just joined their body that they weren't
Okay.
expecting. Yep.
Got it.
And so that is what that clinic is sort of about, and it's sort of identifying patients who are at risk for developing that lymphoma-like condition as early as possible. I'm seeing so many patients now, it's almost to the point that I don't even have enough room to see everybody, but we're getting it done. But it's sort of a passion project of mine. It's a niche because, like I said, it's lymphoma-like. I still see patients who have never had an organ transplant who are just to see me because they have a new diagnosis of leukemia or lymphoma.
Yeah.
But that is um, that is sort of what that clinic is all about. It doesn't really function as an actual clinic. You don't come to clinic and say all of these patients that are here today are
Yeah.
dyslexia. We just sort of use that term to indicate that that is one of my focuses. And I would say it's going quite well. Families feel more educated about this risk. Many times I'm able to graduate patients out of that clinic because they sort of have peaked at the chances that that's going to happen, and then the chances are going down. So I say you don't need to come back and see me, so that I can see new kids that are at risk, and that sort of thing. So
Very nice. Thank you so much for that. I
yeah.
know you have a wealth of knowledge and experience, and one of the ways that you use that, of course, is to contribute in writing. I know I've seen a number of your different publications on like PubMed, for instance. So, if folks have never read what you had to say, what are some of the biggest topics that you cover on a print side?
Sure. And so that actually fits both of my two jobs as well. So
Ah,
in one case, those new therapies that I was talking to you about in my research lab, in finding especially new therapies that help a patient's own immune system fight cancer. Sometimes it's looking for new targets to go after on a patient's disease. So that's one type of publication. It is like the bench research that we do in our lab. We get grants to do that research. We then get data, and then we want to share that data. So that is one type of publication that I put out. The other type is very much related to my patients, and so either case reports or larger conglomerates of multiple patients. And I will say Avian does exist in the current literature as one of three patients in a case. You could almost call it a case series. It's not a case report because there's three
okay.
patients we reported on.
Okay.
And I can always send you the link too if you're interested in what that
Great.
publication was. But I coordinated with two other institutions who had really kind of cases that were difficult like his. And we were
Mhm.
sort of showing people how each of the cases were worked up, how each of the patients, what treatment they received, and sort of the best outcomes we had at that moment for those patients.
Very nice. Okay. So I'd like to ask some technical questions, or in this case, research questions, because I'm fascinated about this. One of the things that I've been doing some reading about, and I want to know if you've come across this before, there are studies that state that daycare can actually decrease the risk for leukemia in children. Have you heard about this or?
I don't know that I've seen that specific study. It's not wouldn't be entirely surprising if we think that some of what causes, well, we do know for sure that children who are in daycare tend to have less autoimmune disease.
Yeah.
And we think that is because they're encountering um, more viruses and things earlier in life. Their immune system is preoccupied with that and not accidentally wanting to go after their own tissues. And so,
Ah,
which is what
okay.
autoimmune disease is. So I know the literature on that. I haven't seen the literature on decrease in kids in daycare. And part of that is a little bit conflicting with some of the epidemiologists. So, our pediatric epidemiology group here is very entangled with our pediatric oncology group. And that's
Okay.
because a lot of their investigators look at causes of, it's epidemiology. They want to know what's causing certain pediatric cancers. And we're actually able to find pre-leukemic clones on the blood spots we get from like children, when they get their newborn screen. It's just a
Yeah.
blood spot. They just put a dot of blood. Actually, I think it's like 5 dots of blood on a card. And then that's what they run all of these tests on the newborn screen, is a dot of blood. And then those cards get kept for decades. And so we're even able, I mean, the blood is dried. People have new techniques for looking at, whatever the material was there when it was dropped, so the DNA and some other components of our cells. And one of the things they're finding is they can find it's not leukemia, but it's a cell that is changed in a way that if it makes another change, it could become leukemia on these blood spots. So it's almost like before we're born.
Okay.
Some kids have this thing lingering there, and we're trying to understand what that really means. Yeah. So,
Okay, gotcha. Now, there's a second thing that I found out. You may or may not have heard about this before. There's been talk about some AI technology, of course, being able to unlock a cure. Like, for instance, there's this device called Marlin, apparently, that can help you define acute leukemia much sooner. And I wasn't sure if you've heard about AI technologies or if you can speak on that. Like, is anything in that realm going to be something super helpful on the pediatric side of things?
I haven't heard of that specifically, but I think what is going to start being helpful is that when we first diagnose a patient, it starts out, we see signs. So their
Okay.
body is showing us signs that we think they have leukemia. And then sometimes we can even pick up the disease in their blood. It's made it out of, so leukemia originates in the bone marrow. That's where all our immune cells are born. Leukemia
Mhm.
is just abnormal immune cells. And so sometimes we can pick up the disease in the peripheral blood as it's circulating around, but almost always we go to the source, we go to the bone marrow, and we take a myriad of studies now. We have so many studies we can do now on disease, but only a few are immediately helpful. So, like differentiating between what type of immune cell is the problem. So, sometimes types of lymphocytes, and so those are a type of cell that make antibodies or that like kill infections.
Okay.
Or are the problem. So B cells and T cells, or is it these myeloid cells, the cells that help us deal with like bacteria, the cells that sort of live in our skin and our guts to make sure we're keeping bacteria where it belongs? Is it those cells? So the myeloid type. So that's the first thing we have to differentiate. And then we start to dig deeper. We want to know how has the surface changed on these cells to go from being healthy looking cells to abnormal cells. And so that tells us something too. That starts to tell us because of what's expressed there. Sometimes that even gives us targeted therapy we can use against
Oh,
yeah. So sometimes
okay.
yeah, that we can use for patients. And then we dig a little deeper and we start to look at what changes have happened in the DNA. Because obviously, if a patient, we assume that if a patient has a leukemia, that those cells are being abnormal, that they're some part of their cookbook. I always call the DNA a cookbook. Some part of the cookbook,
Okay.
the recipe has gone awry, right?
Okay.
So the recipe has gone awry, and so we have to figure out where in the cookbook things have changed. And the reason why that's so important, I think that's where AI is going to come in, is
Mm,
because we start what changes happen in the cookbook um, uh, can also tell us how that cell might respond to different therapies. So almost
okay.
always, if we get it, it's a lymphoblastic leukemia, it's a myeloblastic leukemia. We have specific regimens that we're ready to go with that we know are our tried and true. We call those standard of care SOC protocols that we're going to use for those patients. But the sooner we get inklings that maybe some of those therapies that we want to use might not be effective against the
Mm,
patient's disease, the better for us. Because if their disease isn't responding, then we can immediately be like, oh, that's right. They had this change, and of course they're not responding to these agents. But I think
sure.
AI is going to make us, instead of us having to do, go through the list and go through the literature, because that's really hard. So each patient there are a lot of common changes that we find that we're used to seeing, but when patient's disease has unusual changes, any one of us is not going to remember, oh yeah, when I've seen that or when that happens, then it's resistant to X, Y, and Z drugs. And so being able
Okay.
to like take all that information and put it into a system that then could come back and say, actually, I've looked through all the literature for you, every article that has anything to do with this change. And here are some things you should be worried about, or maybe some therapies that you could use that's more targeted that again, we wouldn't just automatically have in our brains.
Gotcha. Okay. I have one more thing to pick your brain and then I'll
Sure.
ask you about your practice. Very recently, I had heard Dr. Vincent, I don't know, Dr. Vincent Lavelli, if you've heard of him. He's been trying this thing called adaptive sequencing. And so I was curious to ask you, apparently when they're doing this, it helps to not only diagnose, but characterize and also lend you more information about childhood cancer in general. So I was just curious, have you heard of this as of
Do
yet?
you know if this is specifically like clonoSEQ or adaptive? Is the
I
adaptive
don't.
therapeutics?
They
Okay.
literally just phrased it as adaptive sequencing. So I thought I'll just run it past you, see if you've
Yeah,
ever
so
heard of
we
it.
Especially I mean, so we are using a product called clonoSEQ, and we are
Okay.
able to use it mostly for BALL. It's actually FDA approved for being able to follow BALL. So the lymphoblastic, the form that's caused by B cells, the cells that make antibodies. So BALL, the most common the most common actually pediatric cancer. Like that is the poster child for pediatric cancer,
Sure.
is BALL. And so we can send a sample to this company called Adaptive. They do something called clonoSEQ, and so they find DNA sequence signatures, usually up to about three, within a patient's disease, so that we are able to get to the point of about 1 in a million abnormal cells. This has been the biggest problem for leukemia since the dawn of time, is that what do we consider remission? And so remission back in the day was any blast number less than the typical number of blasts in a bone marrow. So we're allowed to have 5% blasts because those are considered I mean, I hate the fact we do this. We call healthy, very early immune cells blasts, and we call leukemia blasts. And this is very confusing to a lot of folks. So
Yeah.
our body should have, our bone marrow should have 5% healthy blasts in it at any given time. When we give a patient chemotherapy in the past, what we had to say was, okay, you've gotten therapy. Let's see if because normally at the start of before we start treatment, they usually have 95%, 100% blasts in their bone marrow. So it's
Okay.
very, very noticeable.
Sure.
You give them treatment. If it was less than 5%, then we say, oh, you're in remission. Again, the disease isn't gone, but we felt like the patient's disease was responding well enough that we could continue the therapy as is to get to cure. Then we started doing this thing with the receptors that I was mentioning.
Yeah.
And with that, the sensitivity of our assay is now we can find 1 in 10,000 abnormal cells. So as long as the leukemia is less than 1 in 10,000 healthy cells in the bone marrow, then we say that patient is in remission.
Got it.
clonoSEQ, this using these sequence, literally going to every letter, like, like every letter, if you think about DNA, it's A's, T's, C's, and G's alternating different. So they come up with, like I said, up to three sequences, and they use that as, are these sequences still present in this patient's bone marrow? And they can get down to 1 in 10 million cells. So yes, it is changing how we monitor the depth of remission so that we can say, oh, this patient actually has more disease than we realized and maybe needs more therapy. Or this patient has
Okay.
less disease than we anticipated at this point. We don't need to further intensify their therapy, sort of thing.
Understood. Okay. Thank you so much for that. Now, as I understand it, you see kids and young adults. So where do you start age-wise and go up to?
Yep, birth. So we have had babies present
Oh,
shortly after birth with leukemia. You can, yep. And then 25 is usually my cutoff, and that's mostly because of the ability to have other services care for my patients within our hospital system. So like our ICU does not want to admit patients over the age of 25. And so that becomes sort of our cutoff. So
understood. Okay. Now, I, as a parent myself, most of us use Google constantly
yeah.
because we don't have the benefit of a doctor all the time. So, what do you say to parents when most of us are like, wait, my child probably has 10 out of 12 of these. I should call Dr. Robin and be like, I know it. This is something bad. So, what do you advise to parents as far as I realize that yes, cancer is a threat for everyone, but how do we not go there? You know what I'm saying?
Absolutely. And so I think it's a little bit twofold. One is that if you're Googling it, you're worried about your child. So I think you should bring your child to a provider, and a provider you trust, hopefully. Hopefully you have um, a a provider that you're taking your child to when they're well, so that when you bring them there when they're sick, you've already have rapport with them. They know you, they're going to be willing to, or not not that people aren't willing to listen to your concerns, but I just think that that's something the reason why I'm doing my subspecialty is because temporarily I sort of become that patient's primary care provider while they're going through treatment. And
Yeah.
I really love that during general pediatrics. So we have to do general pediatrics and then we do our subspecialty learning. And
Yes.
that's how this works. And so I love that part. I love knowing my families. And then when someone comes to me and says, this is what I'm worried about, then I have you know, it's good report. If you still don't have that, there's plenty of providers you can go to and be like, these are the symptoms I'm worried about. And then based on how your child looks, then that provider can decide how much workup is needed then versus let's recheck this in a week and see if things are different. Let's, sort of doing the follow-up. I think the biggest thing I think that's the biggest part, having your child seen when you're truly
Mhm.
worried that something's going on. And then it's advocacy on the part of the parent. So I can't tell you how many times I have heard from patients, families that once they're diagnosed with leukemia, is that I knew something has been wrong for 3 weeks. I knew something has been wrong for 4 weeks. And then we saw somebody and they didn't really do anything. And that's because if the child otherwise looks okay, as providers, it's worse to just immediately jump to that conclusion because so few kids have leukemia, so
Yeah.
many more kids have all these other things. And so I always say things sort of need to declare themselves. So if they're still there a week later or there's new symptoms, we need to be now it's time to be seen again, do the exam again, understanding is there something I can see here, and then starting to maybe do a workup. So I think it's mostly parents having a good relationship with their providers and then also continuing to bring their kid back. I mean, I think you just have to say, you know what, it's still not right. This isn't my child. And then we eventually get to the diagnosis.
You bet. Would it be fair to ask this question? Because I know you have leukemia on one side of the fence, lymphoma on the other side of the fence. Is there such a thing as saying to parents today while listening to this, okay, these are some things to look for? Does that make sense? I mean, obviously, I know it's very vague and you need testing and other things. Any kind of, any sort of red flag we should be looking for?
It's really hard to throw red flags out because in some cases it's one thing for some kids and something
Sure.
else for another. But I think the biggest thing is, and I always talk about this too, the parent's gut, right?
Yeah.
Something inside is saying what I'm seeing is really abnormal. Obviously, things like we all have lymph nodes, right? These lymph nodes are and this is a whole other system in our body that actually drains infections away from the sites they are. They're full of healthy immune cells that get rid of infections that we have. And part of their job is actually to get large when we have an infection, to enlarge, because we're making lots more of the immune cells that are clearing the infection. And
Yeah.
so a lot of parents get really worked up with lymph nodes, and lymph nodes should get bigger but get smaller. But obviously, anything that gets bigger and stays bigger is kind of a
Yeah.
red flag. And I'm gonna try not to push too hard on that because I know that this is not it's a sensitive topic. I would say leukemia is a lot more insidious in the way like there's unless the platelet. So as I was mentioning, leukemia takes over the entirety of the bone marrow. It really I like to think about it as factories. We all have all these healthy factories in there, and
Yeah.
then the cesspool comes in. And with the cesspool, a lot of those factories go on strike. They're like, fine, this is gross. I'm not going to do this anymore. And when they go on strike, then we stop seeing those healthy cells circulating in the
Yeah.
blood. And with the decrease of the healthy cells, it comes in our fighter cells, many of the fighter cells, the most important ones, only last hours. So they're sort of gone first. And then our platelets, which only last, those are the cells that make clots, they only last for 7 days. So once you've made a platelet, it only lasts for 7 days. And so
Oh,
then the platelets go next. And then red cells actually circulate for about 120 days. So usually our hemoglobin, yeah. So our red cells are the last ones to fall. So if we see a kid that comes in where usually two of those types of cells are low, somebody gets a count level on a child, that really starts to get our brains going as
yeah.
far as and so it would be symptoms around those things. And in that case, it's more about having parents talk about what symptoms their child is having, us doing a good
Right.
exam to see if there's evidence that those cells are low, and then, of course, actually getting that test. And sometimes it takes a long time, several visits to actually have a provider want to get counts on a child. And I will see the
Okay.
devil's advocate to that is when we get things to just get them, we find things that are non-relevant to what they're there for, which is why we try not to get tests unless we're ready to understand everything that's on them.
I understand. I
Yeah.
get you. Now, this is the part where you tell me every single patient that you've seen is now in remission and they're all wonderful.
I wish pediatric cancer was amazing that way. We actually just had a really, I personally have, this is like going to get me up a little bit. A patient who thrown the kitchen sink at him at his disease. He has rallied through all of it, and uh, we were able to send him home while I was just on service, and there was a beautiful Make-A-Wish happening today for him. He was escorted to the Wild game, the Minnesota Wild game, and with a police escort, and everybody that loves him was lining the streets as he was on his way there. And it's incredibly beautiful, and I guess I'm just feel fortunate to have known him and his family, and also that people are so willing to, when things aren't going the way we want them to rally around him and his family and give him what he deserves, which is this amazing day that's all about him and everything he loves. So I wish it was so often it is very positive in our field, but it's not always. And
Of
so,
course. I
um,
get you. Now, I got to learn about Avion.
yeah.
Super excited to talk about him, which is how I found out about you, I should say. So tell me first off how you met him. What brought him to you?
So, how our service and many services work is that we see new patients outpatient, and we have the type of patients that should be seen by each of the type of providers. So I'm someone who sees anything that could be leukemia or lymphoma, or I actually see some benign hematology things. If someone has low hemoglobin anemia, they might come see me and for me to figure out what's going on, that sort of thing. And then the other side of our clinical practice is that we take turns taking care of every patient that's in the hospital. So I don't just go to the hospital when my patients are in the hospital. I have a set number of weeks that it's my turn, which I was just doing that. And that's why it took a little bit longer to do this interview, where I take care of everybody that's in the hospital.
Okay.
So that's how I met him the first time was I came on service, I think about 3 weeks. I don't know if I've said this the same every time I've talked to people, but I feel like it was about 3 weeks after he was initially presented. So I wasn't the first person on the oncology service to meet him, but I came on, we just do 1 week at a time. So I was probably like the third provider in our
Yeah.
group that met him. And so that's how I met him. He had been in the ICU. I actually knew about him. Uh, from the providers who had been taking care of him. He was very complex. People didn't feel entirely certain about what was going on with him and how well if we had had the right diagnosis. So we all sort of knew his history, but I only
Yeah.
physically met him a few weeks after he was admitted.
I gotcha. And to those of you that don't know, he eventually was diagnosed with a condition, and I have to physically read this off. The short version being IMCD, which is idiopathic multicentric Castleman disease. Did I say that right, hopefully?
So it's idiopathic
Okay.
multicentric Castleman's disease.
Thank you so much. And to those of you that do not know, and correct me if I'm mistaken on this, Robin, it's often mistaken for other disorders for one. Plus, it's incredibly difficult to diagnose, as I've heard, but you tell me.
Yes, that's exactly right. So that's the best way to sort of sum it up. So the presentation looks like a lot of other things.
Yeah.
So to get to it, we had to sort of rule out a lot of things. He actually met the um, criteria. So when I say that, sometimes when we diagnose things, we're able to do a very specific test, say a biopsy. Like with
Yeah.
leukemia, I do a bone marrow biopsy, or for lymphoma, I do a lymph node biopsy. I send it to a pathologist, and immediately they are able to say it is this diagnosis or it isn't. The thing we had diagnosed him with is HLH, which is even harder to say. So hemophagocytic lymphohistiocytosis,
Oh my.
which is a hyperinflammatory syndrome that in someone his age would occur secondary to something else. So he
Okay.
doesn't. And so he had met the criteria for that. So there isn't one test to say something is HLH. You go
Ah,
through a bunch of criteria, which we did. He checked the boxes. So that was his initial diagnosis. And HLH is a very rare diagnosis. And
mm,
still, Castleman's is even more rare than that. So
I
this is,
understand.
yeah. So that part is really hard to, it was really hard to, we had to get through realizing that it probably wasn't HLH to then start to rethink what else could this be. And that's eventually what we did. And it was, it took from when he was admitted in late July, early August until mid to late October to actually have the right diagnosis.
Okay. And if I understand this correctly, based on my research, some of the bigger ones are you have symptoms like inflammatory symptoms and swollen lymph nodes. And that's putting it very mildly, of course, I'm sure of an array of symptoms. But was he presenting anything out of the ordinary, anything that might have tipped you off, anything at all here?
Yeah. And I will say too, we had to cloud the picture. He was so sick that he was going to die from his hyperinflammation at the start.
Oh,
And so we
gosh.
had to start throwing medications at him just to stabilize his body. And so
Got
that
it.
kind of clouded the picture a little bit as well, because
Gotcha.
actually some of the things we gave him were incidentally treatments for Castleman's. I'm
Okay.
just gonna call it, yep. And
Yeah.
so that sort of clouded the picture. And then other things that started to, it was only later. One, he had HL, we were calling him HLH. Things that still kind of bothered me were his platelets stayed low, and that was kind of this really odd thing to have happen. The fact that
Yeah.
everything else was sort of getting better. So that was another thing was he just had these fluid collection in his belly that wouldn't go away, and it didn't really make sense. He also, we thought he was getting, he was having a problem from you can kind of ruin your joints from steroids. This thing called osteonecrosis that we know can happen when you're on a lot of steroids. And
Okay.
so he was having joint pain. And so we sent him for MRI, and his MRI came back as all of his muscles were full of fluid. And we're like, why are his muscles full of fluid? Which is something
Right.
that you might see in a rheumatologic condition. We usually call that myositis. So that was really unusual. Oh, and he was so deconditioned. I mean, this is the thing that like immediately was such a red flag in my mind. Most of our athletes, even if they're in the ICU with a tube in their throat for a couple of weeks,
Yeah.
they come out not strong, but they can like sit up in bed and, start to work with PT. He couldn't lift his head off his pillow. He was
Oh,
so weak, he
gosh.
couldn't lift his, and he was a three-sport athlete before all this happened. And like all of this deterioration happened over a matter of like 3 weeks. And so that did not make sense either. And so again, sometimes things just don't make sense and we keep checking in on things and we never find anything different. But it was just too many things adding up to me that we were like, we're not quite on the right track. There's something here that we're not quite on the right track.
I get you. And from what I have read, it sounds like you have unicentric and multicentric.
Mhm.
And I heard recently that there has been a third type that's been discovered. Did you know that? Or I just
So
read that.
yeah, so what did it say it was? And then I
I
will.
knew you were going to ask me that. I didn't write it down.
Okay.
I was researching and I'm like, oh, isn't that interesting? There's a third type. And I
Right.
thought maybe you might know, but yes, folks, if you look it up, apparently there is.
Yeah. So, I mean, I usually actually think about it as this unusual umbrella that's a little bit unbalanced. So on one side you do have the unicentric, but then
Okay.
on the other side you have the multicentric. But the multicentric is now like four different kind of
Oh,
subtypes.
wow.
Yeah, so
Okay.
we have the HHV8. That's a virus that can spark all of this off. And Avian did not have HHV8, and I think that's the one that kind of
Okay.
happens maybe more often in adults, or maybe it's like HIV patients. And then there is his subtype, this Tafro. So it's
Okay.
multicentric Castleman's with Tafro. So he had these other array of symptoms. There's one that's not otherwise specified. And so, like, it's not Tafro, it's not from HHV8, but it's still Castleman's. You still have a lymph node that shows a Castleman's pattern, and they're sick. And then there's even like this poems form, I believe, in which it looks more like this disease that's called POEMS. And so,
Mm.
yes, so I'm not sure if that other one is that, like, that it's another one that kind of is coming off the branch of
Sure.
the multicentric Castleman's, or if it's its own. I would just have to look and just see.
Well, that's
But
okay. Or I can send it to you because I have a link and I'm like, yeah, if you
oh,
want to take
sure.
a peek. The
Yeah.
reason I ask is because Avion, which particular type, and more importantly, what was, I don't want to call it the magical cure, but what is it that you used or implemented that brought him back to a healthier state?
Yep. So he has Tafro. His subtype
Okay.
is Tafro. That's an acronym for four, or sorry, four. I'm showing you five fingers, five different um, attributes that
Okay.
those patients have. Remember, I said his platelets were low.
Hmm.
I'm going to use our term for platelets that are low, thrombocytopenia. So he had low platelets, thrombocytopenia. The A is anasarca. Anasarca is our term to mean fluid everywhere in the body, like
Ah,
any,
okay.
so the F is for fibrosis, which happens in the bone marrow. So these patients can have a hard time making their bone marrow because their bone marrow is laying down some extra strands of things that shouldn't be there.
I got it.
The R is for, or actually F is also for fever, and he had those initially.
Okay.
R is renal complications. That was the other thing too. His kidneys kept getting really angry. They would get better and then they would get a lot
Oh,
worse. We even biopsied his kidney at one point. And so, yep, so he had sick kidneys, and sick kidneys are part of it. And then the O is organomegaly, which just means large organs. It usually means your liver and your spleen are large. And
yeah,
guess who had a large liver and spleen? Avion did. So he pretty much checked all the boxes on that. But that didn't diagnose this. And
sure.
so we knew he had his lymph nodes were not, so in lymphoma, and forgive me, but in lymphoma, we tend to see the lymph nodes be very, very big
Okay.
by the time we diagnose things. His were pretty underwhelming. They weren't really big lymph nodes. They were there. When we did our scans on him, they looked enlarged, but
Okay.
it wasn't a defining feature of what was going on with him. But we did get some lymph nodes out, and we were able to send them to someone who's an expert in diagnosing Castleman's from lymph node biopsies. And his absolutely checked all those boxes too. So that's
Okay.
really how we got to the diagnosis.
I get you.
The treatments he was receiving, and this was the big part of that case series that I was mentioning to you, is that
Mm.
every patient seems to respond to something different. Like there's no, like, if you had just given this from the get-go,
Yeah.
this would have been the best. So for him, the steroids were probably helpful because we actually started a medication called ruxolitinib. It's a tyrosine kinase inhibitor that works against something called the JAK2 pathway. And we're now understanding that that pathway for some patients with Castleman's is over ramped up, and that if you use this medication, you actually stop or slow down that process. He got on that because there was a paper in for HLH that said it could work for that disease too. And so he was already on those two and got he got benefit, but that's when he sort of hit a plateau. He never got a lot better. He stopped
Okay.
being ICU sick, but he
Okay.
plateaued with those two medicines. And eventually we had to give him actual chemotherapy. So we
Mm.
gave him 4 cycles
Okay.
of chemotherapy.
I get you. Now, I read very recently, I was so excited because this young man, this beautiful, sweet athlete, said he
Yeah,
wants to open up a gym one
I
day to
know.
help all the other people
Exactly.
that have the same
Mhm.
sort of thing going on. And I'm like, how wonderful is that? That somebody who's been through such a huge, huge crisis is able to say, I want to turn around and make a positive, because most of us know that cancer is just, there's so very little about that. That's a positive.
Yeah.
So I guess the key questions or takeaways here are, first off, most of us parents, no matter what doctor tells us this, will automatically say it must have been something we didn't do, something we missed, something we didn't see, and somehow we're responsible. How would you respond to that as a doctor?
Yep. And I know this is before I get to that though, so Castleman's technically is not cancer.
Right.
It's Yeah, it's an overproliferation, but yes. So, but in with the other
And I
with
guess I should have made
yeah,
that. Okay,
yeah,
so here's
yeah.
the
I
real
wanted to make sure
question.
that
So,
yeah,
editor, take that question out and let's use
okay,
this question
okay.
instead. Um, turning to whether it's a disorder or a disease such as IMCD or looking at leukemia or lymphoma, most of us as parents, because we're primary caregivers, take it upon ourselves to be the knowledge and be all and end all. So when our child becomes sick, it's a natural tendency to blame ourselves or wonder what we've missed. So as a physician, how do you address that?
No, and I hear that almost from every single parent. I've actually preemptively started saying, trying to have a conversation about that with families because I know it's in their mind because so many parents have said that to me. And I think the kids worry about it too, right? Like, what did I do to deserve this, sort of thing.
Sure.
Did I do this to myself? And I've equated it in two different ways before. I think the one that I like a little bit better is you're just out and you're going about your day, and there's a storm that day. You're not being uncareful, but suddenly you get struck by lightning, right?
Yeah.
Like nobody is intending to ever get struck by lightning. Nobody is typically, people aren't doing things that predispose themselves to getting struck by lightning, but people get struck by lightning. And
Yes.
that's what this is. It's like a sudden, random, I mean, not sudden, obviously, it took a little time to come on, but it's a random event. Like you're sort of, it's almost like the bad luck lottery is kind of how I would look at it. And I tell families that because there's nothing they absolutely could have done to prevent it. Most of the time, there's nothing that they could have done to have it be found sooner because again time and again these parents are bringing their kids again and again to providers saying something's wrong, and I always want them to know that there is, I mean, people are constantly trying to scare us about if you gave your child this, they're going to have this. And I think that that is such an injustice right now that parents should have to take that on because this is just something that, by and large, occasionally we'll find a child has a cancer predisposition syndrome. Occasionally, very
Okay.
rarely. Like not even, I think maybe once in my, once or twice in the time that I've been practicing, has that really been the case that the child has this cancer because their bodies were able to allow the cancer to be there. We have something we can
Sure.
blame. Um, but by and large, I let families know that I don't know why this happened to you, but it has. You've come to the right place. We are going to take care of your child and we're going to take care of you. And we're going to, and I always tell them, I'm as honest as possible, but by and large, we can tell our families, like, there'll be a time when you don't have to worry about this coming back. Like, our plan is cure. So let's just do what we
Yes.
need to do to get there. And our plan is cure. So.
My other question is, we as lay people who are not doctors, are there ways or do we have the ability to make a impact as it relates to helping, whether it's through research or other things? What can we do?
Yeah, I mean, that is excellent thing to mention. So, I would say, as a researcher right now, no matter how good my research is, there is an incredibly shrinking pool of taxpayer dollars that want to help us, and it's always been small for pediatric cancer. So I think we're 4% of all of the grants is pediatric cancer, and we're seeing that shrink more and more. So when people can, it's amazing to pair with, say, like we have a University of Minnesota Foundation that that can directly put families dollars to projects that our university has going, or researchers and what they're doing. So when people can, that's amazing. Otherwise, sort of joining, maybe donating to things like what was the Leukemia Lymphoma Society? I forget what their new name is like blood disorders.
Hmm.
But some of these other foundations that award grants to researchers like myself when some of the federal money is not available.
Understood. Okay. Before I forget to ask this, if folks watch this today and they either want to meet Robin in person, meaning are you going to be making an appearance or have events coming up or fundraisers or anything? And then on the flip side, if someone sadly needs your services, how do they go about doing that?
Yes. So, one, I've never felt popular, and so I don't have anything coming up. I'm happy to meet anybody and talk to anybody about anything that they're
Sure.
interested in. I would be, we have, I guess I'm trying to think like the best way of getting a hold of me about like specific cases and things. Usually I just share my email. And I
Okay.
will allow people to reach out if they'd like to.
Okay.
Sometimes it takes me a little bit of time. Like I'm sort of a, expect, 72-hour return
Sure.
on that sort of thing, but I'd be happy to provide that. Folks can also ask for a second opinion through we are M Health Fairview Masonic Children's Hospital.
Okay.
And then um, could have a formal second opinion if there was something specifically that families were interested in. So,
I get you. Okay, good deal. Thank
yeah.
you for that. This has been hugely educational and engaging, and I have learned so much, and hopefully my listening audience has so much. What I want to leave you with, Robin, is this. What I have found in doing this for many years is that one of the things that people never hear enough is gratitude. So I know that I speak for countless numbers of parents and fellow researchers and fellow doctors when I say the work that you're doing literally is not only life-saving, but it leaves an imprint on people. And I don't think you can ever be thanked enough for making a difference in the lives of others. And the fact that you're saving them and trying to save even more every day is amazing. So thank you, thank you, thank you. I can't say thank you enough for it. Everything you do.
I do appreciate that. And I also so appreciate Avion's willingness to have his like I couldn't be here talking about him today if
Right.
it wasn't for him being willing to share how difficult his story was. So that's means a lot to me as well is just his willingness to make sure that others are taken care of because it was so tough for him.
Yes. Thank you so much for that.